Assalamu alaikum. Today we discuss prosthetic aortic wall. I hope you will understand and assess prosthetic aortic wall. For the assessment of prosthetic aortic wall and echocardiography, there are certain key points. Number one, clinically history regarding symptoms and anticoagulation status should be available for each patient. Number two, it is better to have a baseline study for comparison. Number three, knowledge about the type and size of the whale helps in the assessments. It is very important to knowledge about the type and size of the whale. Hemodynamic status at the time of study, especially the level of blood pressure and the pulse rate is important. Opening and closing of the leaflet should be assessed closely. Visualizations of abnormal densities like thrombus, pannus, vegetations, and the prosthetic wall is important. Mean gradient produced depend on the size and type of the well. There is a large range in which is considered normal. For any particular patient, it is difficult to differentiate normal from abnormal. Hence, the need of comparison to older studies. Shadowing may interfere with the assessment of locations and amount of regurgitation. Doppler parameter of prosthetic aortic valve functioning. Number one, peak velocity is less than 3 meter per second is normal. 3 to when it exceeds from 3 meter per second, 3 to 4 meter per second, possible stenosis, and if above the 4 meter per second, the velocity is suggestive stenosis. But there is another parameter we should assess with it. It's is a mean gradient less than 20 is normal, 20 to 35 is possible stenosis, and above the 35 is suggestive stenosis. Another parameter is DVI, Doppler velocity index is 0.30, greater than or equal than 0.30 is normal. If is below the 30.30, there will be possible stenosis. 0.29 to 0.25 is possible stenosis. If is less than 0.25, this suggestive stenosis. Effective orifice area is 1.2 centimeter square. Greater than that is normal. Less than 1.2 to 4.8 centimeter per second centimeter square is possible stenosis, and less than 0.8 centimeter per square centimeter square is suggestive stenosis. Jet contour is, if there is triangular jet, this will be normal. If there is intermediate, there will be possible stenosis, and if the jet contour is rounded, this then will be suggestive stenosis. Acceleration time less than 60 millisecond is normal. Acceleration time less than 80 millisecond is normal. 80 to 100 millisecond is possible stenosis, and greater than 100 millisecond is suggestive stenosis. So how we find the DVI? There will be a formula. Aortic valve prosthesis VTI ratio. DVI is equal to VTI of LVOT divided by VTI of prosthetic valve. You should take both the VTIs, prosthetic aortic valve and the LVOT VTI, then the LVOT VTI divided by the aortic valve VTI. So there will be a DVI. Okay. Etiology per elevated peak velocity and mean gradient per aortic process. Whenever there is will be evaluated mean gradient or velocity, so we clearly carefully study for and looking for the pathological stenosis like obstruction, which is thrombus, venous, and degenerations. Second is functional stenosis like high flow, patient, prosthesis mismatch. Number three, error in the measurements. Number four is pressure recovery or small iota less than 30 mm. Echocardiography evaluation of elevated prosthetic well gradients. Whenever there are elevated gradient across prosthetic aortic well, always look for DVI and jet contour and acceleration time. If the DVI is less than 0.25 to 2.9 and the jet contour is rounded with acceleration time greater than 100, then suspected pathological stenosis like venous degeneration and thrombus. If the DVI is 0.25 to 0.29 or greater than 0.30 and the jet contour is triangular with acceleration time less than 100, then suspect either patient processes mismatch or a high flow state due to elevated gradients. Effective orifice index will help in differentiating between these two conditions. When the DVI is less than 0.25 but the jet contour is triangular with acceleration time less than 100, then consider an error in the measurement, especially improper LVOT velocity. Similarly, when the DVI greater than 0.30 but the jet contour is rounded and acceleration time greater than 100, then think about an error in the measurement, especially improper LVOT velocity or underestimated aortic gradients and the other possibility in subaortic obstruction. Patient prosthesis mismatch. In case a patient prosthesis mismatch with aortic well prosthesis, the gradient will be elevated. DVI will be 0.25 to 0.29 or greater than 0.30 and the jet contour will be triangular with acceleration time less than 100. Effective orifice area index will help in the differentiating this condition from high flow state. Effective orifice area will be less than 0.8 centimeter square or effective orifice index 0.6 centimeter square. In case of patient prosthesis mismatch, prosthetic aortic valve endocarditis. Incidence of prosthetic valve endocarditis is less than 1% and has declined with perioperative antibiotic. It is usually start in the valve ring and extend to and spread to the stent, occluder or leaflet. Vegetation are usually irregular and independently mobile. Density some tissue sometimes it is really difficult to differentiate vegetation, thrombus and sutures. Clinical history is very important. D has better sensitivity for vegetation and abscess in the posterior but not anterior location. If clinical suspicion is high and the study is negative, then repeat the study 7 to 10 days. Thrombus Thrombus is more common with mechanical valve, especially with low INR. It is usually larger and soft density similar to myocardium. Septum are usually of short duration. In the presence of thrombus, it is more likely to encounter abnormal valve motion. If the size of the thrombus is less than 0.85 centimeters square, then it is less likely to embolize. Penis is more common with bioprosthesis. It is usually smaller and dense. Symptoms are usually for longer durations. Approximately 30% may not be visualized. Prosthetic aortic valve regurgitation. In the presence of aortic valve prosthesis, the regurgitation may be physiological or pathological. In case of physiological regurgitation, it occurs at a hinge of occluder in the closing volume of or blood displacement by occluder motions. Pathological regurgitation is usually center, most with bioprosthetic valve. It may be technical or infections related, and in that case may be paravalvular. It is challenging to pick the regurgitation with prosthetic valve due to the shadowing and eccentric jet of axis view may be required. It is difficult to quantify paravalvular leak with width of vena contracta may be difficult to measure. This is about the prosthetic aortic wall. I hope you will understand about this. So assess the prosthetic wall on these criteria. Thank you so much.